it's my absolute pleasure to welcome Associate Professor Ziyad Al Aly, who's an American physician and clinical epidemiologist, who's currently Director of the Clinical Epidemiology Center and Chief of Research and Development at Veterans Affairs, St. Louis Healthcare System. And he's also a clinical epidemiologist at Washington State University in St. Louis, and he's really a superstar in long COVID research. Anyone who's been following long COVID and post-COVID complications would have read his many seminal papers, which have appeared in New England Journal of Medicine, Nature Medicine, and a range of other top journals. So thank you so much, Ziyad, for spending some of your vacation to come here and give us a talk.
Well, thank you very much for this introduction. Really delighted to be here today at Kirby and beautiful Sydney, and to talk to you about long COVID. Thank you, Raina, again for hosting this and for the opportunity to talk. So I was hoping today to talk to you a little bit about the lasting legacy of the COVID-19 pandemic and summarize the research that we've done over the course of the past several years to better understand the long-term consequences of SARS-CoV-2 infection. First of all, I am employed by the federal government, by US government, and the opinions expressed in this presentation do not represent the views of my employers. That's really only mine. But we get funding from the US Department of Veterans Affairs and also the American Society of Nephrology to do the work that we do. So in terms of outline, I'd like to talk to you a little bit about the story, what led us to study long COVID. Why did we, as a bunch of clinical epidemiologists who were prior to the pandemic focused a lot on environmental epidemiology and also on pharmacoepidemiology, decided to switch and pivot in the very early days of the pandemic to study long COVID? Give you a bit of a broad overview of long COVID, our thinking about long COVID, discuss some results regarding the long-term cardiometabolic manifestations of the disease, neurologic and mental health outcomes, GI outcomes, and talk a little bit about the effect of reinfection, effects of vaccines and antivirals. And then, spend a few minutes to sort of offer reflections or a bit of our thinking about, the opportunities and challenges that this really presents. So I do recall vividly what we all went through in March 2020 in the US. There were cases starting in Washington State and New York City, and really exploding or really increasing at a very rapid pace in the very, very early days of the pandemic. And then that was also happening in a lot of areas in the world, Italy and a lot of other areas in the world, and obviously China and Wuhan, where we saw the world in crisis. We saw sort of that the world is, crumbling around us. And really, this is not an exaggeration. All our world was upside down. All of a sudden, there were lockdowns. All of a sudden, there were, these significant changes in our lives, and that risk, the sort of a looming risk. So we asked the question, me and my team, and we're a small team based out of St. Louis, VA. We asked the question, how can we help? What can we do as clinical epidemiologists to pitch in and help a world in crisis? And I do remember at the time, and then we said, okay, we decided that we're all in. We want to try to understand what's happening with COVID. But then, a few weeks later, I do remember vividly sitting on my couch in the living room, and on my laptop reading the New York Times, and here it was an op-ed piece by Fiona Lowenstein, saying that we need to talk about what coronavirus recoveries look like. Everybody at the time was telling us, or telling them, and telling all the world that if you're young and healthy, had no medical problems before, that you got SARS-CoV-2 infection and you'll bounce back really quickly and recover really quickly. But she was basically saying, well, that's not the case for me. I was young and healthy previously. I did not have any medical problems. I got SARS-CoV-2 infection, and weeks later, I still have many problems related to SARS-CoV-2 infection. And then that's really sort of if you really think about it, that's really the index case of long COVID. That's the first known report published in a major publication or by a major publisher, New York Times, really reporting what long COVID is, long before the disease even had its name, long before it was even called long COVID. And so really very important that index case was not reported in the New England Journal of Medicine, was not really reported in the Lancet, was not in the BMJ or Nature Medicine or anywhere else. It was in New York Times. It was an op-ed piece by a really, in my view, a pandemic hero, and where she spoke the truth and she told her story. And it didn't stop there. It did not stop there. What really happened here is that a lot of patients were experiencing similar problems. And to their credit, and this is really very, very important in the history of medicine, to their credit, these patients coalesced around each other and then started talking and sharing experiences and really flooded her inbox, her mailbox. And then started forming into organizations and groups, advocacy groups, really the most notable of which is what we call now the Patient-Led Research Collaborative. And what they did is really, really, really smart. They actually started surveying their membership. It was an uncontrolled experiment. It was really everybody in their membership had SARS-CoV-2, was complaining of lingering problems in the weeks that followed the initial infection with SARS-CoV-2. So they surveyed their membership and they published their first report, and they called it an analysis of the prolonged COVID-19 symptoms by the patient-led research team. And that's really, if you really also think about it, that's really the first known report in humanity, in the history of mankind, of what long COVID is. Long before it even had its name. So this will go down in the history of medicine as really a major inflection point where patients, for the first time in history, patients actually told us that this disease exists. They surveyed their membership. They told us what are the characteristics of the disease itself, and promoted awareness that we as medical community need to pay attention to this, need to study this, need to be thinking about this. And they didn't stop there. They also, in that report, they chronicled, weakness, fatigue, brain fog, muscle pain, joint pain, et cetera. And very, very shortly afterwards, the patient community, Elisa Perego, an Italian archaeologist, coined the term long COVID. And the patients started referring to themselves as long haulers. So this is a disease that was first described in an index case in the New York Times, the first survey of which was published by a patient-led group, no physician, no researcher from an academic world, really the patient-led movement. And they coined the term, or they really gave it its name, long COVID, and started referring to themselves as long haulers. This is all a first. There's nothing like it in the history of medicine. This is really, really unique. There is nothing like this in the history of medicine, in annals of medicine, throughout our history of 3,000-4,000 years of medicine, the medical profession dating back to the Greeks. This is really a first. This is really enormous and really very, very, very important. These are the true heroes of long COVID. These patients are actually the true heroes of long COVID. So I do remember sort of going through the data from these patient groups and thinking to myself, well, this is really great, but it's an uncontrolled experiment. There was no control group. When you publish a survey of all people who have problems, you don't have a control group. So yes, maybe 10 or 20% or 30% have fatigue, but what's the prevalence of fatigue or the incidence of fatigue in the control group? It was an uncontrolled experiment. It was very, very important, but uncontrolled. So we simply decided to do the controlled experiment. We simply decided to say, okay, we don't know, we don't really know what this disease is. We want to understand it better. And then to more deeply understand it, we need to develop a controlled experiment. We need to have people with SARS-CoV-2 infection and then compare them to a bunch of control groups who did not have SARS-CoV-2 infection, and observe them over time, over a 6-month period in this paper, to try to better understand what's happening to them. And that's sort of what led us to this early work. And because at the time we did not know what long COVID is, because we did not really, postulate or have even enough information to hypothesize that it may involve cardiovascular manifestations or neurologic manifestations, we use what we call a high-dimensional approach. It's a hypothesis-free approach to better understand all the post-acute sequelae of SARS-CoV-2. And what we found is really, really remarkable, was really eye-opening for us. And that was the first time where we oh my God, is this really truly happening? Is this, the patients were right, they're seeing all these symptoms in multiple organ systems, and in a very controlled experiment, in a very, what we think is a good and rigorous scientific experiment. we were able to see increased risk of mental health disorders, increased risk of neurologic problems, metabolic consequences of the infection, GI problems, skin problems, coagulation and hematologic disorders, a lot of CVD or cardiovascular disease, respiratory problems, kidney disease, musculoskeletal disorders, and as well as fatigue and other manifestations. So it's very, very, very clear to us from that point that the post-acute sequelae of SARS-CoV-2 are not really confined to the pulmonary system. It was not only brain fog or fatigue, it was really a range of sequelae in multiple organ systems. And that was sort of one of the major findings. And then we said to ourselves, well, is really SARS-CoV-2 really unique? Is it really unique? Because there are a lot of other viruses. Let's say, take, for example, seasonal influenza, that can also put people in the hospital, and sometimes they may have post-acute sequelae of flu. So we did a comparative analysis comparing SARS-CoV-2 versus seasonal influenza. Well, we found that the magnitude of risk was higher in SARS-CoV-2 versus seasonal influenza. And also we found that the breadth of organ dysfunction is much more extensive in SARS-CoV-2 versus seasonal influenza. So we concluded at the time that it was really a different kind of post-viral illness, that maybe you get also post-viral illness with seasonal influenza, but it's very, very clearly that with COVID or SARS-CoV-2, it's a different kind of post-viral illness. What we saw is also important is that the risk was evident, was very clearly present in people who were not hospitalized for SARS-CoV-2 infection, meaning people who had mild disease who nursed it at home and did not have any severe symptoms that would necessitate hospital care. Those patients, they're very important because they're a majority of people with SARS-CoV-2. Most people with SARS-CoV-2 infection in the world are not hospitalized for it. They have mild variety of disease. They get acute symptoms. They may get over them in a week or in a day or 2 or 3 or 4 or a week or 2. So even in that group, some of them went on to experience post-acute sequelae of SARS-CoV-2, what we call long COVID. But the risk increased in a graded fashion according to the severity of infection, meaning that people who were hospitalized had a higher risk, and people who needed intensive care had the highest risk of post-acute sequelae of SARS-CoV-2. And if you look at this slide and say, oh my God, Ziyad, you're showing us this is all over the place. This is really, it's a sort of an all over the place slide. You know what? You got the right conclusion. If you get from the slide one thing, that SARS-CoV-2 is non-monolithic. It does not all behave in the same way. When people sort of, reduce the complexity of long COVID to one sentence, it's like, oh, long COVID is more common in this group or more common or less common in this group. They're reducing the complexity of literally a lot of sequelae to one line. And I think what we show here is that some sequelae or some consequences of infection, long-term consequences of infection, are more expressed or more abundant in older adults, but some are more expressed or more abundant or more pronounced in younger adults. Some are actually more prevalent or more expressed in females or women, and some are more expressed in males. So, when people talk about sort of risk profiles of long COVID, ask them, what are you talking about? Are you talking about brain fog? Are you talking about metabolic consequences? Are you talking about fatigue or post-exertional malaise or POTS? Because they don't all behave in the same way. And each of those entities, each of those sequelae, the components of the sort of broader long COVID, have their own risk profile. So really resist the urge to reduce the complexity of long COVID into sound bites or simple sentences. It's not really a simple disease. Most importantly, I want you to take from this slide, it's not monolithic. It's a non-monolithic disease. It does not all behave in the same way. So at the time, we sort of started thinking a little bit, okay, so we now know from our prior work that SARS-CoV-2 can lead to consequences in the heart and diabetes and metabolic consequences. And we wanted to do a deeper dive into these sequelae of concerns. And we did. So this is our first paper, so looking at the cardiovascular outcomes of SARS-CoV-2. And in this work, we took about, a little bit more, about 150,000 people, a little bit more than 150,000 people with SARS-CoV-2 infection, and compare them to, close to a little bit more than 11 million controls. Some are contemporary controls and some are historical controls. And what we were able to see here is that people who had SARS-CoV-2 infection a year out, in the 12 months that follows the initial infection with SARS-CoV-2, patients were coming back to the clinics or coming back to the hospital with an array of cardiovascular problems that included cerebrovascular disease, brain problems, including stroke and TIAs, dysrhythmias or abnormal rhythm of the heart, inflammation of the heart, ischemic heart disease, other cardiac disorders, and thrombotic disorders. So it's very, very clearly, it was not really only just heart attack, with an array of cardiovascular disease or cardiovascular problems in the year that follows SARS-CoV-2 infection. And then we ask the question, is this really, does this also follow what we've seen before, the trajectory where people who had mild disease they have evidence of infection, and then that the risk of infection increases according to the severity of the risk of long COVID or the risk of sequela increases according to the severity of infection. And it's totally true here too, that the risk of these post-acute sequela increases in a graded fashion according to the severity of the initial infection. This is very, very clearly illustrated here on this slide. And we wanted to understand, well, is this really a disease of only old people? Like old people have a higher risk of getting heart attacks, heart failure, thrombotic complications, et cetera, et cetera. So we did the analysis here to parse it by age, sex, race, cardiovascular disease at baseline, obesity, smoking, hypertension, et cetera, et cetera. Well, we saw that it didn't really matter if you're old or young. It didn't really matter if you're, had obesity or didn't have obesity, if you smoked or didn't smoke, if you had hypertension or not. There was still increased risk of cardiovascular sequela in the year that follows SARS-CoV-2 infection. And that's really very important. So the risk is not necessarily only present in people who had prior cardiovascular risk factors. It's very, very clearly present, even if people did not have prior cardiovascular risk factors, including lack of, they're not obese, they're not smoking, they don't have hypertension, diabetes, or chronic kidney disease. And then we sort of pivoted to understand a little bit the metabolic complications or the long-term metabolic complications of SARS-CoV-2. And what we saw here is that people with SARS-CoV-2 infection in the year that follows the initial infection, in the post-acute phase, and in the year that follows the infection, there was increased risk of diabetes, and that was, again, evident in people who were not hospitalized at the time, increase in people who were hospitalized, and highest in people who had been hospitalized in the intensive care or required intensive care. And that was, the diabetes in those patients in some cases was severe enough to necessitate the initiation of antihypoglycemics. And so that's a really, very also important signal that has been replicated now in more than 20 studies. There are meta-analyses showing pretty much the same thing in multiple studies, from different cohorts throughout the world, that SARS-CoV-2 infection is associated with the increased risk of diabetes. And then the metabolic complications or consequences are not confined to diabetes. We very, very clearly saw increased risk of hyperlipidemia or abnormal lipid profiles. And that, again, that question was actually inspired initially also by the patient advocacy groups, and a lot of them were sharing that they had these metabolic consequences or metabolic problems. And very, very clearly, we see it in our data too. And these are, again, literally millions of people, analyzing their data over a year and showing that people who actually got infected with SARS-CoV-2 in the year that followed the infection, they had an increased risk of hyperlipidemia or high cholesterol that involves high LDL, low HDL, and high triglycerides. So all the components, and in some cases sufficiently, severe or sufficiently, high to necessitate the initiation of lipid-lowering medications. And then, so I'm sort of partial to the kidney. So a lot think, my prior before our work on COVID, and long COVID, we did a lot of work on kidney disease. And so we wanted to, and Charlie and my team was very, very interested in trying to understand the eGFR trajectories. eGFR is a marker of kidney function. It's called estimated glomerular filtration rate. It is a marker of kidney function. We wanted to understand what happens to people's kidney function in the year that followed the initial infection with SARS-CoV-2. What we saw here is that even when people had mild disease, even when people had very mild disease that did not necessitate hospitalization, they were experiencing an eGFR decline, a decline in kidney function in the year that followed the infection that measures about 2 to 4 milliliter per minute per year. You should be asking now, what does that really mean? What is a eGFR decline of 2 to 3 milliliter or 2 to 4 milliliter per minute per year really means? What that really means is that their kidneys have aged in 1 year, have aged about 4 years. So that's equivalent to the kidney aging 4 years in the span of just one. So you can start thinking about it that initial hit with SARS-CoV-2 is almost tantamount to accelerated aging, that you, instead of growing only 1 year older, let's say if you're 50, instead of like becoming 51, all of a sudden biologically you're actually 54 in terms of kidney function, just because of that hit with SARS-CoV-2. You can start conceptualizing it as an accelerated aging issue, that sort of it really accelerates the underlying processes of aging in the body. And specifically here, very, very visible, very, very clear with the eGFR trajectory, because this is very sensitive to age. And all of us experience natural decline in eGFR with aging. We usually experience about 1 milliliter per minute per year. 4 is aging about 4 years in the span of 1. And this is very, very sort of a, very, very commonly sort of a observed phenomenon in adults. So Jan and my team, we were thinking at the time also like a lot about mental health consequences of SARS-CoV-2 infection. And we're thinking that all of us during this pandemic have endured a lot of stress. There were a lot of stressors. There were lockdowns. We couldn't travel to see family. We couldn't travel to see friends. We had really, dramatic changes in our lives, and we were exposed to a lot of stress. So we sort of thought to ourselves, where everybody is stressed and everybody has sort of exposed to sort of the stressors that are related to the pandemic. But do people who have SARS-CoV-2 infection, do they have it worse? Do they really have a much higher burden or a much higher risk of mental health problems than the people who were not infected with SARS-CoV-2? And the answer is very, very clearly yes, that people with SARS-CoV-2 infection in the year that follows the initial infection of SARS-CoV-2 have increased risk of anxiety disorders, depressive disorders, stress and adjustment disorders. And in some cases, that actually resulted in increased utilization of antidepressants, benzodiazepines. And that was accompanied in a lot of patients by neurocognitive decline or changes in neurocognition, what generally referred to, you'll hear about it in the press, brain fog. That's sort of the term that colloquially people use to describe this. And a lot of sleep problems, sleep disorders, and some of them were initiated on sleep medications. So while all of us who did not at the time have SARS-CoV-2 infection were stressed out and experiencing, all these problems, some of us endured grief because of loss of a family member, a lot of stresses related to changes in work, lockdown, et cetera. People with SARS-CoV-2 infection had a much higher burden, a much higher risk of mental health problems. And again, here in this analysis, we compared it to seasonal influenza because we wanted to know, like, is SARS-CoV-2 really different? And it is, in the sense that it actually is associated with higher risk of mental health problems than seasonal influenza or being admitted to the hospital for any other reason or any other cause. And then we shifted our attention after this to sort of trying to understand what happens in the brain. At the time, we started receiving a lot of data from patients and a lot of from sort of the basic science groups that are that SARS-CoV-2 may be neurotropic or maybe sort of maybe associated or has predilection to affect the brain. So we looked systematically at the neurologic sequela of SARS-CoV-2, and what we were able to see here in this paper, that there was increased risk of strokes, increased risk of cognition and memory disorders. That's sort of what people refer to as brain fog. But not only that, there was increased risk of what we call episodic disorders. That's headaches and seizures, things that happen episodically. So headache is actually commonly described in people with long COVID. Although much less on the absolute scale, but seizure disorder is also evident in people with long COVID. Again, mental health disorders, musculoskeletal problems, and sensory disorders. Should not be news to you that people lose their sense of smell and the sense of taste. This is sort of not really novel, but to be comprehensive here in this paper, we catalog all the neurologic consequences, including sensory disorders and other neurologic disorders. So it's very, very clear here that the risk also increases according to the severity of infection. The risk of long COVID is highest in people who needed ICU care, but evident, still very clearly evident. It's not zero, it's still evident, even in people who had mild disease that did not necessitate hospitalization. And this is a refrain in our studies. We always do these sort of group analyses where we study the risk according to sex and age and based on risk factors. And it's very clearly here that the risk was evident even, for example, in people who did not have any immune dysfunction prior to SARS-CoV-2 infection, because it's like, oh, maybe all the risk is concentrated in people who had immune dysfunction or immunocompromised. And yes, they are at higher risk, but even people who did not have any immune dysfunction, they are still, at increased risk of these problems for sure. And so to conclude our, multi-system sort of investigation, we looked at the gastrointestinal manifestations of SARS-CoV-2. That also should not be news to you that a lot of people report constipation, diarrhea, irritable bowel disease, some abdominal pain, et cetera, et cetera. So this is really sort of been also reproduced abundantly in the literature. I'm going to spend a little bit of time to talk about this paper on reinfection. So about maybe like a year and a half ago, we started thinking that a lot of people in the world have already been infected once. So for them, the question whether they should go ahead and protect themselves from being reinfected from a first infection is really no longer valid, right? Because they've already been infected once, right? So the question, if you already had prior infection, the question that you already would be struggling with, is it worth it for me to protect myself or my loved one from being reinfected, right? So that's really, so to do this analysis here, we did what we call a sort of counterfactual experiment. We assessed the risk of reinfection versus a cohort had been infected once and did not get reinfected, right? So no reinfection. So infection or reinfection versus no reinfection. And assess the risk over a 6-month period to try to understand the acute and post-acute consequences of reinfection. It was very, very clear in this data that reinfection is consequential. And I think a lot of people like to trivialize it and say, oh, like, I've gotten infected once and that's really, then I have solid immunity and I don't really need to worry about masking. I don't really need to worry about being reinfected. I don't really even need to take the vaccine, et cetera, et cetera, et cetera, because, I've been previously immunized by natural infection. And that's really is not borne out. I mean, it would be wonderful if it was really true. It is not true based on the data. It's very, very clearly that reinfection contributes additional risks, both in the acute phase and in the post-acute phase of the disease. And then when we study the effect of multiple infections, it seems to be cumulative in the sense that 2 infections are worse than 1 and 3 are worse than 2. It's very, very important. 2 infections are worse than 1 and 3 are worse than 2. It doesn't really mean that the first infection does not confer any protection. It just means that if you add to it a second insult or second infection, your outcome after 2 is actually worse than just having 1. And I think this is really sometimes misinterpreted in the media, but that's really exactly how we interpret it, how we conceptualize the analysis. So you should be asking now, well, we've seen long COVID, the SARS-CoV-2 has been now around for a number of years, and how long is long COVID, or how long does it last? And the answer is long. Long COVID is actually really long. So how long is long COVID? It's really, really long. So this is our assessment of 2-year outcomes of SARS-CoV-2 infection, and we again divided the groups into non-hospitalized, people who had mild disease to start with, and then people who were hospitalized at the time of the initial infection or the acute infection with SARS-CoV-2. And what we see here is that, for a lot of these sequelae, the risk horizon, some of the risk horizon sunset at 1 year, some of it as at 18 months, and some of it at 2 years. But even in the non-hospitalized group, there's still about a third of these sequelae did not reach the risk horizon. What does that really mean? That really means that these patients are still at risk of these problems even 2 years later. Obviously, not all the sequelae, but about 1/3 of the sequelae, about 2 years later. And that risk, that was actually 2/3 in the hospitalized group. So really the infection with SARS-CoV-2 is consequential, and not only in the immediate term, it carries long-term risk. And when people sort of conceptualize long COVID, it's like want to talk about long COVID recovery and sort of the risk horizon for these sequelae. It's really long, and you know, even among the non-hospitalized group, it's very, very clearly that for some sequelae it exceeds 2 years. Now we're looking more deeply at 3-year data now, hoping to share it soon. But I think this is one of the, you know, this is one of the things that we're learning about this infection or this SARS-CoV-2, that the post-acute sequela or the risk horizon for these conditions is really not short. So I spent a lot of time thinking or telling you a little bit about the problems with long COVID, but I want to sort of you know, switch a little bit gears now to talk about sort of what can we do to prevent it. And obviously, the best thing to prevent long COVID is to prevent COVID in the first place, and that's really, really, really very important. That you know, long COVID does not exist without COVID. If you don't have COVID, if we didn't have COVID or SARS-CoV-2 on Earth, if we just go back to a counterfactual world where there's no SARS-CoV-2 on Earth, there would not be any long COVID, right? So there's no long COVID without COVID. So abrogating or reducing your risk of exposure to COVID in the first place is really the best thing you could do. But there is also vaccination. And this is data from our team, but has also been reproduced abundantly now in a lot of papers, more than 20 papers now and counting, that vaccines do reduce the risk of long COVID. Not by a whole lot, but they certainly reduce the risk of long COVID. There's a lot of heterogeneity among studies and variation among studies, but it's very, very clearly that we see it in the post-acute phase of the disease that vaccines offer protection against long COVID. And then for those who qualify to use antivirals in the acute phase, which really include older adults or people who have risk factors for progression of severe COVID-19 illness, we think that using antivirals in the acute phase, nipping it in the bud or controlling that virus or reducing that severity of infection in the acute phase is key to reducing the risk of long COVID later on. And this is data that's led by Yan and Taeyong from my team in JAMA Internal Medicine in 2023, you know, showing clearly reduced risk of long COVID, or the journal prefers to call it the post-COVID condition, or PCC. By the way, different people in the world call it differently, PASC or PCC or long COVID. Here, the journal prefers that we use the word PCC or post-COVID condition. But the data is very, very clear that treatment with Paxlovid in the acute phase of the illness reduced the risk of the post-COVID condition or long COVID by about 26%. And I think that's really you know, important to know that the risk reduction is there. It's not really huge, but it's not zero. The challenge with Paxlovid is that in the US and also in Europe and in Australia is only prescribed generally for people who are older adults. You know, if you're young, you don't qualify, or if you're young, you have to have a medical condition that predisposes you to progression to severe COVID-19 illness. So that's not for everyone, but for those people who really qualify for Paxlovid use or for antiviral use in the acute phase, you know, using or taking antiviral in the acute phase may reduce the risk of later on of post-COVID condition. And here is data from the BMJ on molnupiravir, also led by Yan and Taeyong from my team, you know, showing that molnupiravir, the other antiviral, which has actually quite, you know, extensive list of side effects, and it is mutagenic, so it's not sort of the most benign thing on earth. However, it's been shown to be effective in the acute phase, and in our work here, there is some effectiveness in reducing the risk of long COVID. Again, it's very small. I mean, if you appreciate here, is, you know, the risk is a little bit above 0.8, so it's really not a huge risk reduction. It's about 15% risk reduction, but it's not zero. It's not null, and it also reduces the risk of hospitalization and death in the acute phase and in the post-acute phase. So I think these two studies, along with others, you know, there's one study from Japan, from Shionogi Pharmaceutical, suggesting that a new drug, enceltravir, it's an antiviral against COVID-19, also in their phase 2 and phase 3 reduced the risk of long COVID. So all these arrows are pointing in one direction, that suppressing the viral replication early on during the acute phase, nipping it in the bud, putting a lid on it, you know, sort of trying to suppress that viral replication, trying to suppress that inflammatory, you know, cascade in the acute phase, you know, seems to be beneficial in reducing the risk of long-term consequences of SARS-CoV-2 infection. And talking about that, so I cannot give you a talk about long COVID or our work about long COVID without sort of mentioning what are the mechanisms that potentially drive long COVID. And the short answer is that our understanding of this is evolving. We're learning about this. We didn't know anything about this 4 years ago. We're learning what long COVID is. We're learning about the mechanisms of long COVID. I think one of the major hypotheses is that of a viral reservoir, is that the persistence of the virus in immune privileged sites, and that for some reason, for whatever reason, patients who end up having long COVID actually do not clear the virus completely in the acute phase, and some of it still persists in the body for weeks or months afterwards in quote unquote immune privileged sites. And does not have to be the full virus. It can actually be fragments of the virus, fragments of RNA, or fragments of protein that sort of persist in the body. The other hypothesis relates to microbiome dysbiosis, the idea that within each one of us, there are actually more bacterial cells than human cells. Ed Jung had actually written a book about it called Multitude. Within each one of you, within each one of us, there are actually more bacterial cells than human cells. So we think of us as, oh, Ziyad is a human, he's a walking human, but within Ziyad, there are actually more bacterial cells than human cells. But we think of ourselves as humans, but we're literally vehicles for trillions of bacteria that outnumber human cells. And the idea is that our health and disease state is actually influenced by the health of the microbiome that's within us, the trillions of bacteria that live within us. Again, we think about us as humans and we care about human cells and human blood and human urine and human kidney, but within us, there are all these, like there's a huge organ or the huge sort of a microbiome. And that too is affected by SARS-CoV-2. So when we get sick, they get sick too. These trillions of bacteria inside you, they also get sick. And the idea that some of the disease manifestations is driven by the microbiome dysbiosis, by that dysfunctional microbiome that is unable, or for whatever reason is, could not heal completely from the viral infection, that contributes to disease later on. There is this idea of autoimmunity or immune dysfunction leading to long COVID, and that's sort of been hotly debated. The idea that the immune system could be either too strong and start attacking self, generate autoantibodies, or to try to generate sort of attacks against self, that's the autoimmunity, or could be too weak, to sort of, again, that may reconcile with the viral persistence hypothesis, too weak to be completely able to clear the virus. And there is also the hypothesis that there may be some blood clotting going on. People sort of think a lot about microclots and sort of the endothelial injury and blood clotting as a potential mechanism that may explain why some people have brain fog, why some people have fatigue, post-exertional malaise, POTS, and other organ dysfunction. And dysfunctional neurologic signaling is also one of the hypotheses. So all of this are hypotheses. They're being worked on by a lot of people around the world to try to better understand why an infection that initially we thought of as an acute infection leads to long-term manifestations or long-term sequelae down the road. So spent some time talking to you about prevention, and I told you that the best way to prevent long COVID is to prevent COVID, but you could also use vaccine and you can use antivirals if you qualify for them. So what about treatment? Do we know anything about treatment? And the unfortunate reality is that we have no treatment for long COVID. We have no treatment for long COVID. Literally, like the number of approved treatment for long COVID in the US, in the European Union, or in Europe, in Australia, everywhere else in the world is zero. No one has a treatment yet for long COVID. And I think that's really a big miss, but also an opportunity to do better, to try to channel our resources in an area where it has been not a whole lot of development, not a whole lot of activity in the past several years. And for the people who are suffering from long COVID, for the people who are out there who have brain fog, for the people who are out there who have fatigue, who have post-exertional malaise, whose lives are ruined by long COVID, that treatment cannot come soon enough. They really want it. They want it, and they deserve it yesterday and the day before, like not tomorrow. So we feel that we need to do better collectively as a community of scientists and also governments to really channel more resources in finding treatment for long COVID, because that's ultimately what matters to patients. we can sort of pontificate here like we understand the epidemiology of long COVID, but for the people who are impacted, for the people who are actually suffering from these conditions, some of them are at home or not able to leave home because of profound fatigue or post-exertional malaise, or not able to work because of brain fog or other manifestations. So for those people, they need and want and deserve treatment yesterday. So when I think about long COVID, I really think of it as an umbrella term. And I think this is really an important slide to sort of help us understand sort of what long COVID is. Long COVID is not one thing. It's not only brain fog or fatigue. It's really an umbrella term for all the post-acute sequelae of SARS-CoV-2 infection. All of them, all these sequelae, we put them under this umbrella term of long COVID. And there is substantial overlap with post-hospitalization syndrome. If you open the literature from 10 years ago, 20 years ago, people who spend time in the ICU or people who spend time in the hospital, they get out of the hospital disoriented, with poor sleep. Sometimes, obviously, it's not everyone, but some people experience problems that resemble, that have some overlap with some of the manifestations of long COVID, right? There's clearly also post-intensive care syndrome. It's like, if you spend time on the ventilator in an ICU, you'll come out deconditioned with fatigue and all sorts of problems. Could also be sleep problems, brain fog, like manifestations that resemble very, very, very clearly, very, very closely brain fog. And this idea that SARS-CoV-2 is really not unique. There are a lot of infections, if you really look very carefully in the literature and in the past 100 years, a lot of infections that were thought initially to be only cause acute disease, like the flu actually, or influenza, EBV, Ebola, polio, and measles, can actually cause in some instances long-term illness. But we've ignored this. We didn't really think about it a lot. We didn't fund it. We didn't research it a lot. But if you really look back at the very early days of the 20th century, following the 1918 Spanish influenza, there were waves of people with what they call at the time encephalitis lethargica, or sleepy sickness, or Laura Spinney has a book called Pale Rider, in which she chronicles the aftermath of the 1918 Spanish flu. And she writes very, very clearly about those things. There were reports, anecdotes all over the place in Europe and Africa and a lot of other places of people reporting back with brain fog, fatigue. Does that sound familiar to you? That's long COVID. That's long flu. So it was there 100 years ago, chronicled in her wonderful book called Pale Rider. And measles can cause long-term manifestations. We now know that EBV, or Epstein-Barr virus, very, very, very common, can cause multiple sclerosis later on. If you look at actually very carefully at survivors of Ebola, there is post-Ebola syndrome and post-polio syndrome. And MECFS, or the entity that's called chronic fatigue syndrome, is also thought to be triggered by an acute infection. So all these sort of anecdotes, if you weave them together into the larger narrative, larger story, put all these pieces of the puzzle together, it's very, very clear that infections that are thought to only cause acute illness or acute disease can actually, in some cases, not all the time, but in some cases, also lead to chronic illness. And SARS-CoV-2 is unique, and it's not. It's unique in the sense that it's novel, the novelty of SARS-CoV-2, and the scale of SARS-CoV-2, billions of people infected in a short amount of time. That's definitely unique, right? Novelty and scale. But the idea that viruses can produce long-term illness should not be novel. I think we made it novel by ignoring all the precedent facts, all the facts that were actually all the arrows and all the pieces of the puzzle and all the evidence that accumulated in the 20th century. We marginalized these illnesses. We put them on the side. We ignored them. We ignored MECFS. We did not want to look at the longer-term trajectory of people with flu or EBV. And now we're discovering, EBV causes multiple sclerosis. Oh, there is like people with the flu also sometimes can have long-term illnesses, et cetera, et cetera. So what are the implications for health systems? So I think the burden of long COVID is likely substantial, on the relative scale, also on an absolute scale. It's not a small thing. Long COVID is not one thing. It's really a multifaceted disease that can affect nearly every organ system. And this long COVID thing is likely to lead to a rise in the burden of chronic diseases, including cardiovascular disease, diabetes, kidney disease, and some of it will be actually shared by the GBD group later on this year. I cannot emphasize enough that these people need care. Like patients with long COVID need care, and that really highlights the importance of post-acute care strategies. When we think about, when most of us really talk about COVID or talk about the pandemic, it's very, very important that you all sort of think that we're talking about the tip of the iceberg. Most of our systems, most of our dialogue, most of the narrative that you see in the press, most of our politicians and public health leaders, when they talk about COVID or the pandemic, they're literally talking about cases, hospitalization, and death. Cases, number of cases. Oh, I have like this many cases with mycoplasma pneumonia, or this many cases of COVID, or this, and how many people in beds and hospital beds, they care about that. That's important. That's very, very important. How many people are in beds and how many people subsequently die, right? But that's only the tip of the iceberg. Infections can also cause chronic disease, including now SARS-CoV-2 causing long COVID. And that's really what's invisible, because it happens later. And a lot of these patients are literally in their beds at home, suffering sort of the invisible from the public debate, and a lot of times, and suffering, alone. It contributes to disease and disability. It also reduces life expectancy. There is an impact on educational attainment of kids. Has profound economic implications. There is a David Cutler from Harvard. He and Larry Summers predicted in very early in the pandemic that there were about $2 trillion in cost, and then David revised his estimate to long COVID costing the economy, the national economy in the U.S. in the order of $3.7 trillion. So it's not a small problem. Again, that economic analysis by David has a lot of assumptions, but again, it's a figure that to help you appreciate the magnitude of the problem, that it's not really a small problem. Its impact on the economy is not really small, at least in the analysis done by David and Larry Summers. So the economic implications of this are profound in terms of labor participation, et cetera, quality of life, et cetera. We worry a lot about impact on sustainable development goals. So I think we prior to the pandemic, if you look at the metrics, look at the data, I felt like very, very positive about the world. The world was getting in a better place. We were improving. We were actually improving the health of populations around the world. We were making actually progress, not uniformly across all SDGs, but if you look at the metrics, you think, oh my God, we are as a planet, we're actually doing a good job. Not a perfect job, but a good job in addressing the common challenges that we all experience around the globe. So, and the pandemic hit, and I worry, and now we're starting to see indicators and data indicators that there is a lot of reversal and a lot of these meritorious, salutary, beautiful trends, a lot of reversal in that progress. Again, eroding decades of progress. Again, that reversal is not like really, one step forward, one step back. It's one step forward, 10 steps back. It's really that magnitude, and the data will be coming out from the GBD group like very soon in the next few months. Remarkable reversal in progress. It's not really a small thing. So it will take us years to sort of catch up and compensate and recoup for that sort of a reversal in progress in SDG. And there are very clearly social implications. So to long COVID. I would like to conclude by offering some reflections on challenges and opportunity. And this is really by all means not comprehensive, but just a starter, and then we'll go to a Q&A, hopefully, so we can have a more interactive discussion. So in terms of challenges, I sort of personally feel that the care of people with long COVID needs to be more optimal, is really suboptimal around the world. And actually in many cases, especially in low and middle income countries, it's really totally absent. And so those people are suffering. They actually exist in low and middle income countries, contrary to popular belief. They exist everywhere in the world, but they're not being taken care of. And then a lot of times sort of to the policymakers in those parts of the world, like, oh, the problem doesn't exist because you don't even have the infrastructure to even recognize it. So I think that's really very, very, very important point to be made. We feel very strongly in my team that prevention strategies are underutilized. We see loss of appetite for masking, but not only that, loss of appetite for good filtration and ventilation systems, loss of appetite for even vaccination. Appetite for vaccination in the United States is waning. Vaccination rates are not where they need to be, and now we're on the way. It's getting cold. We're starting the winter season in the United States, where both flu and COVID are likely to surge, and then the data is now showing an uptick in both flu and COVID, an early uptick in both flu and COVID, in the CDC dashboards. So we think we're not doing very well on prevention, and we know how to prevent it, but we're not implementing those measures. As I said, one of the major challenges is no treatment for long COVID, and that's really a missed opportunity. No consensus on terms and definition, no systems to measure the burden of infection-associated chronic illnesses. And I think that's really very important, because if you don't measure it, you cannot really talk about it, credibly. You cannot really sort of, advocate for allocation of resources. It needs to be measured like we measured cancer prevalence and HIV prevalence and kidney disease prevalence and diabetes prevalence. We need to be able to quantitate the effect of infections on chronic disease, be able to measure it and show the WHO and the world and our local governments and our national governments the impact of infection on non-communicable disease prevalence in each area of the world. And I think that's really an underdeveloped area of science that should be developed further. We don't really know a whole lot about the long-term risks. I get asked a lot by the media and a lot of other places, where does long COVID or does SARS-CoV-2 cause increased risk of cancer? The answer is that we don't know. We don't really know, because it's really too early to sort of assess the latent manifestations of disease, things that take years to manifest, maybe 5 years, 10 years, 15 years to manifest. So we don't really know the effect of cumulative multiple infections on risk of cancer later on. We don't really know. And I think one of the major challenges is the politicization of the pandemic, or politicization of public health in general. And I think we sort of a public trust in public health in the United States and throughout the world was at a certain level before the pandemic. And I feel we're emerging from this pandemic with even loss of trust, not more. So this is also another, step in the wrong direction, right? I talked about, eroding decades of progress in public health and global health with SDGs, right? Eroding decades of progress. This is also eroding decades of building trust with communities and the public, and about, importance of science, vaccination, and public health. So there's a lot of misinformation out there. I don't really need to sort of preach to you about it. Disinformation, anti-vaccine movement in the US is rampant, very strong and growing. And this really rising tide of anti-science, you're literally hated for being a scientist. Nothing else, not the color of your skin, not because my name is Middle Eastern or something, for being a scientist. And that's luckily new to me. I guess you could be hated for something else, but now it's like for being a scientist. So you're literally hated for being a scientist. And that's really strange. However, there are opportunities. There are opportunities here. I think the scope of the scale of the pandemic is really a golden opportunity and historic opportunity to study long COVID, to learn as much as possible about it, because it will not only help us understand long COVID, it will also help us understand infection-associated chronic illnesses, unlocking a better understanding of how infections can cause chronic disease will not only help long COVID, it will really help us understand more about infection-associated chronic illnesses. And I would argue the third pillar in that is really also help us weather the challenges of future pandemics much better. So you should also, policymakers and you guys and all of us should be thinking about it as also a core component of pandemic resilience and preparedness. And that's really important. This is a historic opportunity. And I tell people in the US that we already paid the price for this horror show. This is a horror show. We all went through a horror show of the past 3 years or 4 years of the pandemic, right? Some of us lost loved ones. We had a lot of grief, a lot of stress, infected. A lot of people had, long COVID. So we paid a heavy price in the US alone, more than 1.1 million people dead. We already paid a very heavy price, a heavy toll for this horror movie, right? Might as well learn from it. Learn from this horrible experience that we actually just all experienced. And failure to learn from it will would be a tragic mistake, will be an historic and tragic mistake, because basically we already paid the price up front. So we must learn as much as possible from this, because we already paid the heavy price. The 1.1 million dead in the United States are already dead, right? So we might as well honor their death and their losses by learning as much as possible about this. So when we go into the next pandemics, and pandemics are going to happen. This is one of the certainties of life. We just don't know if it's going to happen next year, 10 years, 5 years from now. We don't know, right? But they're going to happen. And maybe the same magnitude of the COVID-19 pandemic, maybe more, maybe less. We don't know. We don't know, right? But we need to be better prepared to face the next pandemic. I think one of the beautiful things that happened also in this story is that, I think for the first time in history, patients really emerged as partners in research and partners in driving public health and driving a better understanding of long COVID. And that's really absolutely amazing. And I think we need to do better in prevention. That's very important. There's a lot of talk about improving ventilation and filtration systems, vaccines, mucosal immunity, antivirals. We need to do better in finding treatment. And really, most importantly, not most importantly, also importantly, the data systems and expertise to be able to build better surveillance and epidemiology systems for post-acute illness. That's really very, very important. And what I call like developing systems to be able to do real-time, real-world evidence generation. That's really profoundly important to help us not only better understand long COVID, but also be able to weather the future challenges that we are certain to face. So in summary here, patients aspired and continue to aspire our journey, really enormously grateful to them. Long COVID is a multifaceted disease that can involve any organ system. Talked about the importance of post-acute care strategies. We made some progress on prevention, but we really need to do a whole lot for treatment. I highlighted the link between infectious diseases and chronic illnesses and offered some reflection. Really grateful to my team. We're not a huge team, but we're a small team, but really, Yan and Taeyong and Charlie and Evan and Meow and other team members. Grateful for the support from the U.S. Department of Veterans Affairs, R&D service at the VA, including Susan Wood, who is absolutely amazing. Ali Schaefer, the VREF, or the Veteran Research and Education Foundation, executive director, and the public affairs people at the university who promote our work really wonderfully, specifically Christina Sauerstein and Diane Williams at Washington University. We have openings, so if anybody are interested in a postdoc fellowship, we have openings for people in pharmacoepi and also clinical epi, and would be delighted to do a Q&A.
Okay, thank you so much, Ziyad. We've got you on a very tight schedule, so we can only take a couple of minutes of questions. I might just see if there's anyone online. There's lots of questions online. I'll just have to pick a couple. I think he's already sort of answered some of these. Are there any reports of prolonged mesenteric adenitis being reported in kids post-COVID?
I haven't seen any, but that doesn't really mean it doesn't exist. I have not seen any.
I think Nada Hamad, were you online? Wanted to ask a question? No? Not there. Deepti is asking, we've recently been hearing from some scientists that long COVID is not much of a problem because of reduced risk with Omicron and vaccination, widespread population immunity. What would your response be to these arguments? What does your work suggest?
Well, I think so. Vaccines reduce the risk of long COVID, but we have not seen any credible evidence that long COVID is any less with Omicron than prior subvariant or variants or subvariants. So, and in fact, I don't want to talk on the record, but we do have a work coming out, sort of it's not much less with Omicron than prior variants for sure. But vaccines reduce the risk because the vaccine utilization remains suboptimal, and a lot of people are not keeping up to date with their vaccines. And a reduction of risk with vaccine is not huge. It's there, but it's not like it doesn't really totally eliminate the risk.
Sorry, I'll come to the room in a minute, but there's one more question from Nada Hamad. Has there been any analysis into parity versus risk of long COVID? This seems a logical explanation given the peak incidence in the 30 to 50 age group.
So this is really a wonderful question. It goes back to my slide, like to resist the urge to simplify long COVID into one single thing. There are manifestations like brain fog and fatigue and post-exertional malaise that may be more prevalent in younger adults. There are metabolic complications or cardiovascular manifestations that are more prevalent, or the incidence of which is higher in older adults. So I generally, when I talk about long COVID, because it's a really broad umbrella term for a lot of things, I resist the urge to sort of to simplify to simple statements.
Thank you. We'll just take the 3 questions in the room and we'll have to stop there, I'm afraid. Thanks everyone else for your other questions. Smita.
Thank you. I'm Smita Shah, a clinician at Environmental Healthcare Institutional Research Unit. I really value what you just presented because we've been working with community in prevention. I have 2 very quick questions. One is the use of nasal sprays in prevention, and what's the evidence and what nasal sprays should we be using? I've been hearing about a whole lot of different sprays out there. know about that. And the second question was on the issue of you said there's increased risk for cardiovascular and other system diseases for patients. So when they've had long COVID, what can you tell them? What do you tell the patient about how to decrease their risk? Is there any work being done on what should be told to the patient? Because there's no use just telling the patient you've got increased risk. You need to give them some sort of hope or some direction. So any thoughts on that?
Sure. So first of all, like prevention effort, it's very clear to us that the best way to prevent long COVID is to prevent COVID in the first place, like what you're doing now, masking to reduce your risk. You're not going to be able to eliminate your risk by reducing the risk. The second, I think, really important that we invest a lot. We have invested over the past 50 years in upgrading building codes to make them earthquake proof, right? To seismic proof, right? There's no reason why we shouldn't demand, like our government should demand, better filtration system and ventilation systems and indoor. So we spend literally millions of dollars, maybe billions of dollars in the national economy in the US to make sure that buildings don't really fall down when an earthquake hits every 100 years, right? So pandemics are going to happen on much more frequent measure, right? So there need to be a national discussion and a global discussion about thinking forward, how do we improve the air quality, especially indoors, to really mitigate or reduce that risk, right? We do that for again, earthquakes, right? Earthquakes don't happen every day, but we invest billions of dollars. Building costs a lot more to make it earthquake proof, right? We invest billions of dollars just to make sure that they're safe, right? Why can't we do the same thing for air and make sure that it's safe in the setting of a pandemic or the next pandemic, right? And then very clearly vaccination, needs to be ramped up. And there is also the development of mucosal vaccines that reduce or block transmission. Current vaccine technologies don't do very well in blocking transmission, right? They have some effect, but not very good in blocking transmission. I think we need to evolve our vaccine approach to include vaccines that induce strong mucosal immunity to block transmission, and also evolving the pipeline of antivirals. So people who actually get SARS-CoV-2 infection, how can we sort of nip or try to reduce that viral infection early on and make it available to a broader set of people.
So we'll move on to the next question. Valentina, because we're over time.
Hi, thanks for the amazing presentation. My question is regarding of treatments, because you say before, we have zero treatment for long COVID at the moment. But I mean, is there expected to be a treatment for long COVID? As you expect so many different organs, like for example, a cardiovascular problem coming for long COVID, will you not treat as a cardiovascular problem, or are we waiting for actually a long COVID treatment?
This is brilliant, and it also goes to your second question. So currently, let's say, for example, somebody showing to the clinic with tachycardia, right? So we treat them as if they have a tachycardia from other sources, right? They could be having tachycardia related to long COVID, but let's say if you treat individual A with beta blockers, right? You may treat this person also with beta blockers to reduce their heart rate, right? So current treatment approaches don't really differ based on whether the etiologic agent for that tachycardia was SARS-CoV-2 or they were going to have tachycardia from something else, right? So at this point, we don't really differentiate, but I think this is really an area that we need to be delving deeper into to try to gain a better understanding whether tachycardia that ensues following SARS-CoV-2 infection has the same response to treatment that the tachycardia comes in from other etiologic agents, right? So I think that conversation needs to be had and that research needs to be done. But at this point, somebody shows up to the clinic with, I don't know, diabetes from SARS-CoV-2 infection, right? Who've never had any risk factor for diabetes. They're generally treated the same way we treat any other diabetes person from obesity or something else.
Thanks. Last question.
I'm Judy. I'm one of the GP. I just want to ask you the question about, so since there's no treatment, so we must focus on prevention. Can you comment on the recent Sweden study about vaccination? Actually, the more up to date with vaccination, you actually reduce the long COVID risk.
Yes.
As well as metformin or other kind of cheaper treatment, and also our lack of XBB vaccination in Australia would actually increase our risk in long term for long COVID because we don't have the right vaccination for neutralizing antibodies.
Yeah, this is really very brilliant. So it's very, very clearly, this beautiful BMJ study, Swedish study in the BMJ recently, showing also, again, risk reduction of long COVID with vaccination. If you got one vaccine dose, the risk reduction, I think like 20 or 30% increases more with 2 vaccinations, 3 vaccinations. So vaccines reduce the risk of long COVID. If you look at the broader evidence base, including this study and then the 20 other studies have been done, very, very clearly there is a reduction in long COVID. The effectiveness of vaccines in reducing long COVID ranges between 15%, to 75%. We wrote a piece recently, it's not published yet. We sort of, on average, that reduction or the mean reduction or the effectiveness of vaccines is about 40%, right? And it varies by study, it varies by vaccine doses. Obviously, like you said, like 3 doses are better than 2, or 2 doses are better than 1, right? And metformin, there's encouraging data from David, from University of Minnesota in the States. And he had a really nice trial that was published about several months ago showing that the metformin use in the acute phase reduces the risk of long COVID by 41%. 41%, that's not small. That's not huge, but not small. So
we have to wrap up.
Yeah. Yeah, so I think with very encouraging data, we need more. Yeah, we need to understand it more.
Okay, thank you so much, Ziyad, and thanks for all the questions and the attendance. Sorry we couldn't get to all the questions, but we've got to take Ziyad somewhere else now. So thank you very much. This is just a small token of our
Thank you. Thank you.